Ladies and gentlemen, good afternoon and welcome to our ESPEN webinar about successful prevention and therapy of malnutrition in older persons, which is part of the Malnutrition Awareness Week, which is starting today. My name is Dorothee Volkert. I am professor for nutrition in older people at Friedrich Alexander University in Nuremberg in Germany. And with this focus on older people in my everyday work, I'm very happy that this event today is dedicated to this population group, which is very vulnerable indeed to nutritional problems and malnutrition in particular. And I'm very happy that you are all here and that we have such a huge audience and interest in this topic. The webinar takes place in collaboration with the EuGMS, the European Society for Geriatric Medicine, and the MNI, Medical Nutrition International Industry. And I would like to welcome you also in the name of my co-chair, Nuno Mendonça from University of Lisboa, who will take over the moderation for the second half of the webinar. Before we now start with the presentations, I would like to invite you to ask your questions, if you have questions, to the speakers in the chat function. So the discussion of your questions will then take place at the end of our webinar. We will have some time specifically for your questions then. So now we directly start with the first presentation, and I'm very happy also to announce my dear colleague, Professor Jürgen Bauer, who is a geriatrician and gastroenterologist. He is professor of geriatric medicine and head of the geriatric hospital Agaplesion Bethanien at the University of Heidelberg in Germany also. And his talk is about the relevance of nutrition in the context of good aging. And I am very much looking forward, Jürgen, to your presentation.
Thank you, Dorothy, for this nice introduction. And it's a real pleasure for me to give you this lecture this afternoon. I will talk about the relevance of nutrition in the context of good aging. And first, I want to provide you with some backdrop, with some background information about the real size of aging during the years to come. Until 2050, the global population aged 60 and beyond will double to 2.1 billion. And the number of persons aged beyond 80 is projected to triple between 2020 and 2050. And we have to say we really focus very much on this population, the older people beyond 80, which are at highest risk of malnutrition. The global life expectancy will further increase, and which is also relating to the real aging in the current population is the information that there are now already over 700,000 centenarians worldwide, and the UN projects over 3.7 million centenarians by 2050. So the former pyramid of aging is turned somehow nearly upside down. This is the projections up to 2100. And you see the large percentage of those beyond age 80. So we really have to check on this really special population in this society. And we have to work on it because, you know, aging societies, it's a gift to many of us because good aging is possible. But it's really a challenge to modern societies. As with aging, the percentage of persons with limitations and especially with disability really increases, like is shown in this graph from Eurostat from 2025. So aging is a gift somehow for many of us, but it's also really demanding for many societies because, like is shown here, we will need more doctors and we will need more nurses to take care of the diseases and the disability of older citizens. But this is something which can be worked on. We can try to really improve the scenario. And you see here The rather bad scenarios, the blue one is the one which is relating to the current state of health systems, and it can get worse. Of course, it always can get worse, but it can also get much better. Much better if we work on the resources of the older population. So the prevention of functional decline should be a top priority to avoid overburdening of healthcare systems in aging societies. How can we understand this aging process? Of course, the frailty concept is something like a concept that really addresses biological aging. It's characterized by reduced reserves and diminished resistance against stresses. Of course, there are negative health outcomes related to frailty. So we have to work against frailty on intrinsic capacity. We have to work on the functional capacity of those that are growing old. And for the preservation of these reserves and the prevention of dependency, nutrition is really of utmost importance. So this is the background, now really zooming in on the nutritional status. You know, that's the patient career with aging. It's a threat to autonomy and independence. And it's a mix of aging factors, lifestyle factors, and of course, nutrition is a very important lifestyle factor, and age-associated diseases and malnutrition, sarcopenia, and frailty are among them. And which has to be very clear, aging makes older persons vulnerable. And this vulnerability is very much related to nutritional status. And this is something you see in older citizens, and you only see this in another age group, and these are the newborns, the very small children. In between, I think we are sensible towards a worsening nutritional status, but the real relevance is the highest in the oldest individuals. And to be very clear, what is malnutrition? I think many of, or most of you know, it's a state of energy and or nutrient deficiency caused by inadequate intake, inefficient utilization, or heightened requirements. And in the older people, it's mostly protein energy malnutrition that we are facing. Malnutrition may come with disease-related inflammation, it may be disease-related without inflammation, and it may be seen without any disease at all. I think my colleagues Marian and Gülistan will really dive into that later. Well, you hardly see, or at least the percentage is much lower, like I will point out in a few minutes, to see protein energy malnutrition among healthy, active older adults. It's much more widespread among those requiring care and those with acute and chronic illnesses, like I've already shown in this graph. However, we should be aware that we will see persons with malnutrition in all care settings, in the community, in nursing homes, and of course, especially in hospitals. Here are some prevalence numbers that have been published 2019 in Clinical Nutrition. So we expect a prevalence of malnutrition in older patients in hospitals between 15 and 25%. The prevalence rate in nursing homes should be expected to be between 10 and 30%, in the community 5 to 10%, and which is very much important. The likelihood of being malnourished increases in dependency from your functional state. So if you are disabled and you are cared for by home care services, you may face a 35 prevalence rate, which is much higher than in the ones that are independent. This means malnutrition is a challenge to older societies and, for example, also for the European Union. It is expected that we have about 4 to 8 million malnourished older persons among community dwelling older persons, and the rate should be, absolute number should be around 1.2 million among institutionalized older persons. And I've already pointed out malnutrition is a threat to independence and to function, but it goes much beyond. And of course, functionality is very much interrelated also with a high number of disease states, like infections, falls and fractures, which are also directly related to sarcopenia. We see an increased rate of pressure ulcers, impaired wound healing, in total an increased risk of complications from a multitude of other diseases. And there's, of course, an increased risk of hospitalization, nursing home admission, and longer length of stay. The risk of mortality is increased up to 3 times. And of course, all this comes together to really reduce the quality of life in older persons. This is a graph that shows you the vicious cycle of weight loss, sarcopenia, and loss of appetite. And like you can easily understand that malnutrition will trigger the deterioration of sarcopenia, which will decrease activity, and this lower level of activity is very much related to a loss of appetite. And this may go on, and lead to a really serious damage to function in older persons. So what we have to be aware of, quality of life very much related to function very much related to sarcopenia, frailty, of course also cognitive function, which we are not going there today. So we have to understand these very much overlapping entities of sarcopenia, frailty, and malnutrition. Another characteristic of weight loss and increasing state of malnutrition in older individuals is this kind of stepwise decline of weight. And this may be triggered by a multitude of trigger factors, like in this example of a lady that's about 85 years old. She acquires widowhood, then some years later pneumonia, then she's admitted to a nursing home, then she falls and finally has a hip fracture. So there are 2 different trajectories of weight loss, which is smooth, slowly, but also the stepwise approach is very much common. And I think the stepwise approach really characterizes the situations when we should find cases and really tackling them. Therefore, I find this graph very instructive to tackle malnutrition in the older population. And I just want to show you some information about the outcome relevance of malnutrition in hip fracture patients from a publication from 2016, which was very nice. It was covering 215 hip fracture patients, 83.5 years old, mostly female. It was clearly shown that depending on your state, being well-nourished, at risk, or overtly malnourished, your readmission rate really increases towards malnutrition. And during a 36-month follow-up, it was very clear that you also suffer from a much higher mortality, in this case, which was more than doubled. You also have to be aware of that the etiological factors for malnutrition may be seen in parallel. So it's in most patients, older patients, it's not one single cause that's triggering malnutrition. It's some overlap that's adding up to the catastrophe. And this is just a roundabout estimation of percentages that refer to several larger group of causes that cause malnutrition. Disease-related causes, and here especially 10 to 15% neuropsychiatric disorders like depression and dementia, 20 to 30% anorexia of aging, which is lost appetite for a multitude of reasons, 15 to 20% socioeconomic, and this has to really be aware of because in quite some countries, there's really a threat towards poverty in older age. So we should also be aware of this factor, 10 to 15% medications and 5 to 10% functional disability, for example, paresis of the arm, really driving the state of malnutrition. Coming back to the medication, medication is really causing different factors that are leading up to malnutrition, which may be anorexia, which is very much many people are aware of, but it may also be impaired taste and also xerostomia, dry mouth, and this is in the clinics very much underappreciated. So we should work on the awareness that medication very often causes a trigger factor that is leading up to malnutrition. The medication can cause nausea and drowsiness, which also contribute. Depending on the setting, the most relevant factors clearly differ, like is shown here by a publication from our colleague Kiesewetter from Germany. And what is very clear, the number of factors increases the likelihood of becoming malnourished. So we really have to expect different factors leading to malnutrition in different settings. We meet people that are at risk or that are overtly malnourished. So there's nothing what can be done. We have to screen, we have to diagnose, and we then have assess. But this is the message that you will learn from the next presentation by Mary. So I would like to summarize, not to be too long today. Aging societies, like I've shown you, are profoundly challenged by the increasing need for nursing care and by the high number of expected older individuals that are dependent. The prevention of functional decline in older persons must be a priority of modern healthcare systems and of society as a whole. Nutrition is clearly of utmost importance for the preservation of autonomy and for the preservation of quality of life in older persons. Malnutrition induces a wide range of complications and increases dramatically mortality in these older populations, and the vicious cycle of malnutrition, sarcopenia, and anorexia must be interrupted. I thank you very much for listening this afternoon. So, thank you.
Thank you, Jürgen, for this very clear and interesting introductory overview about the importance and the relevance of nutrition in older people. I would directly go to the next presentation and invite Marianne de van der Schuren to give her lecture. She's a professor of dietetics at Hahn University of Applied Sciences in Wageningen University. And her talk is about diagnostic approaches for the screening and diagnosis of malnutrition. And she will highlight current news and new aspects regarding diagnostic approaches. Please, Marianne, the floor is yours.
Well, thank you for the very nice introduction, Dorothee, and thank you also for your first talk, Jürgen, because it very well precedes my talk. I hope you can see and hear my screen and hear me. If not, please indicate. Within GLIM, we have worked on malnutrition risk screening for the past few years. We concluded that the GLIM screening procedure needs to be revised for 3 reasons. First, as already indicated by Professor Bauer, there is a huge pressure on healthcare and a more preventive approach of malnutrition risk screening is necessary. Because risk screening precedes malnutrition, and the earlier we intervene and the earlier we identify at risk, and those will be large numbers, the better we can prevent. And as said in the infographic that was shared today through the socials, we have to avoid malnutrition in older adults at all costs. The second reason to revise the GLIM procedure is that the agreement between the current screening tools and the GLIM malnutrition diagnosis is poor. It raised the question if in some cases you can even directly proceed into the diagnosis of GLIM without doing the screening step. In the original GLIM screening procedure, you screen for risk of malnutrition with any validated screening tool. But what do we mean with any validated screening tool? If you dive into that, you see that any validated screening tool can mean either you have risk factors for future malnutrition, you have mild signs of malnutrition, or you are already malnourished, you have probable malnutrition. And when we talk about malnutrition risk screening, we talk about all 3 of them, and we don't have a definition for what do we mean with malnutrition risk. And as we have done our work over the last 3 years, we concluded that it's completely lost in nutrition land. Some tools screen for risk factors, other tools screen for overt malnutrition, some tools are reactive and other tools are proactive. So we need to make a definition of what is risk of malnutrition. And we raised a project group within GLIM. You can see the participating people here. And we have 3 goals. One is to conceptually define what is risk of malnutrition. Second goal is to operationalize the concept of malnutrition. And the third one is to give recommendations on how to proceed with screening within GLIM. So the first step was the definition of risk of malnutrition. We have 2 versions of this, a professional version and a layman version. As you're all professionals, I'm presenting the professional version. And the conclusion is risk of malnutrition is a dynamic state, meaning that it can fluctuate with or without unintentional weight loss. It can also be without weight loss, but it can also include weight loss, in which an individual has one or more risk factors that may result in malnutrition and may negatively impact the clinical outcomes. And the risk factors are within several categories: nutrition impact symptoms, disease-related, physical, psychosocial, demographic, and economic risk factors. This conceptual definition was presented at ESPEN last year. And the second step was how do we operationalize this definition? So we did a literature research, and we had a Delphi panel, and then we found that 29 factors were critically important to define people at risk of malnutrition. 10 were important and 19 were between important and very important. We defined it as substantially important. And the 29 critically important risk factors were categorized in 8 categories: unintentional weight loss, nutrition impact symptoms, disease-related factors, physical factors, psychological factors, decreased food intake, food assimilation, and poor diet. Of course, there were also substantially important risk factors. For example, demographic factors. Where does a person live, an older person live, and is he married or not married anymore? Economic factors, as already pointed out by Professor Bauer, or social factors. How then do these first 2 studies translate into practical recommendations? This is the old GLIM procedure. The first step is screen for risk of malnutrition using any validated screening tool. This is changing. This has changed. The first step is identify subjects with risk factor for malnutrition. The next thought you have to make is, do we need to screen for malnutrition at all? Because there are some wards and there are some patients and in which you know that the risk of malnutrition is very high. This is the ICU, or for example, the geriatric ward in a hospital. You know that over 90% of your patients will be at risk of malnutrition. Our advice is then to skip the screening step and to proceed directly into the GLIM diagnosis. But there are also populations, and you don't know how many are at risk of malnutrition. For example, the community, between 10 and 20% will be at risk of malnutrition. Then, which tools are appropriate for malnutrition risk screening? So for screening for risk of malnutrition as defined in our conceptual malnutrition. We did a literature search and we found 40 tools that we rated for content validity, risk of malnutrition. And these are the top 5 tools that came out of that literature study. Well, the Chinese nutrition screening tool is specifically focused at the Chinese population, but what you see, the other 4 tools, most of them are specifically aimed at older adults. NAFI, Determine, the short form of the MNA. The PT, SGA is appropriate to all populations in all settings. So these are the top 5 tools that we recommend. So let's continue with our examples. The second example is a population of older adults in primary care. You do know how know their malnutrition risk. So you choose not a generic tool, but a population-specific tool because they're older adults. And you might want to choose either the Determine or the short form of the MNA. And in this example, I chose the short form of the MNA, which asks for an intentional weight loss, nutrition impact symptoms, disease-related factors, physical factors, psychological factors, and reduced food intake. If a person comes out at medium risk or high risk, you can proceed into the GLIM diagnosis and start your interdisciplinary intervention. However, a person may also have additional risk factors from the 29 risk factors that I presented before. For example, poor dentition or being widowed or low financial situation. If a person has additional risk factors and you think that they might influence the malnutrition diagnosis, but they are not picked up by the MNA short form, you can check these risk factors and also proceed into the GLIM diagnosis and the interdisciplinary intervention. So, concluding, what we used to do before is to screen for signs of probable malnutrition, and it is now changing into either 3 of these probabilities. You can screen for risk factors, you can screen for mild signs, or you can screen for probable malnutrition. This will result in many more people being at risk of malnutrition. So this means that we have to widen our network. Who is identifying and treating the ones at risk? This may be nurses, dietitians, doctors, but also social workers and carers of patients at risk, because the numbers will be growing. And this is not something we can do just as healthcare professionals. We have to do it in a broader context. For future research, we also have to realize that the diagnostic accuracy to compare a screening tool to the GLIM diagnosis is no longer appropriate, because the GLIM diagnosis diagnoses malnutrition, while risk of malnutrition is a stage preceding before that. So we have to take a different approach for the diagnostic accuracy. So what we have to do instead is that we measure whether risk of malnutrition screening is able to early identify patients at risk of malnutrition and then prevent malnutrition. So in conclusion, our recommendations are that we do not use any validated screening tool, but that we proceed into a screening tool that also covers the risk of malnutrition. And so we should not only screen for malnutrition, but also for risk of malnutrition. And I saw this infographic today, and it said implementation of routine nutritional screening and diagnosis of malnutrition. And my suggestion would be to add implementation of routine nutritional risk screening to also identify those at earlier risk. And finally, to consider to apply the GLIM criteria directly without prior risk screening in those at high risk, for example, the geriatric hospitalized population. And with that, I would like to thank you for your attention, and I'm glad to answer any questions if there are questions. Thank you very much.
Yeah, thank you very much, Marian, for this very interesting lecture. I think it is indeed important to identify persons at risk, to identify malnutrition or problems early for preventive actions. So thank you. And with this, I hand over to Nuno, my co-chair, who will introduce the next lectures.
Hello, everyone. Thank you, Dorothy, for the introduction. We now have Gulistan Bahat. She's a geriatrician and internist and a professor of geriatrics at Istanbul University, and also the co-leader with me of the SIG nutrition for EuGMS. She'll briefly talk to us, not briefly, but she'll talk to us about prevention and measurement of malnutrition in all healthcare sectors. Please, Gulistan.
No, thank you so much. And I would like to greet everybody. Now I'm sharing my screen. You are seeing my screen well? Okay.
Yes, it's not in presentation mode,
Yeah.
Gulistan. Now it
Thank
is.
you.
Thank you. Thank you.
Okay. My topic is prevention and management of malnutrition across healthcare sectors. Here are my conflict of interest. First, I would like to present the scope and significance, which you can already said very briefly. I will go through it, and then I'm going to talk about the prevention and management across healthcare sectors. And at the end, I have a call for action for everybody listening this webinar. So coming to scope and significance, as we all know, the malnutrition is a clinical condition that is resulting from the lack of intake or utilization within the body of nutrients, and it causes loss of skeletal muscle mass, and it causes weight loss, and at the end it's harmful for physical and mental functions, and is very well known to worsen the clinical outcome. There is a variety of causes of malnutrition in older age. This is also from a paper from one of our co-chairs. And you see here there are a variety of factors that cause malnutrition in older age. Poor appetite, chewing problems, dysphagia. The restrictive diets are very well-known factors as well. Poverty, some social problems, as Jürgen just said, the dry mouth, the poor dental state, very common comorbidities like cancer, Parkinson's, stroke, and poor appetite related to aging itself, and many other comorbidities, as you see, including dementia. So there is a various causes of malnutrition in older age. So the prevalence is really very high. So it's a major public health challenge increasing with age, and it's also common across all healthcare stages for an older adult in the community, in the acute care, and also in the long-term care. And that's a pity that this burden has remained nearly unchanged, almost unchanged for decades. I would like to show you this figure now. You see that for disease-related malnutrition, the prevalence is about 35% in oncology. We know that the oncological diseases are very well known causing malnutrition, but as you can see in older adults, it's even more common than it is in oncology settings. So to have a rough value, the malnutrition in older adults are present among older adults in hospital, about 40%, in nursing homes, again 40%, and in community dwelling persons, among the independent living ones, it's about 5%. On the other hand, as Marianne just said, we have GLIM criteria, and with use of the GLIM criteria, which is endorsed by major scientific societies worldwide, the prevalence of malnutrition in older adults is even higher, about 50% in hospitals and nursing homes, and about 10% in community dwelling older adults. And I would like to withdraw your attention here as well. We know that the percentage of older adults living in community dwelling setting is more common. It's more frequent. While the percentage of malnutrition is less common in community dwelling older adults, we can see that the number of older adults with malnutrition is more common in community dwelling setting, because the absolute number of older adults is much more frequent, much more common in community dwelling settings. So we should be aware that the malnourished older adults are mainly in the community settings, not only in the institutions or in the hospitals. So we very well know the clinical and economic consequences of malnutrition. It increases infections and comorbidities, it decreases wound healing, increases treatment needs, increases length of stay, of course, increases costs, delays to recovery. It impairs the quality of life and causes mortality. It also causes reduced survival from surgical complications. Also, among patients with cancer, it causes dose-limiting toxicities and reduced treatment response. And coming, especially for older people, it causes hip fractures, pressure injuries, which is a really very serious concern for us. It causes falls in older adults and sarcopenia and frailty. And I would like to show this graph also. As you see, for disability and survival, the overweight body mass index is better for older adults. And as you can see here, for obese people, the mortality risk is less than for those who are malnourished. So more pronounced than obesity, malnutrition is a risk factor for mortality in older adults. It causes high economical costs, we see, and what is good is the nutritional care improves clinical outcomes and lowers healthcare costs. We have many randomized controlled trials, prospective studies, and meta-analysis showing that there is significant clinical and economic benefits across patients groups in different settings. For example, we can have a comparison with very frequently used medications. You see the number needed to treat to prevent one death. The lower the number needed to treat is, the better is the effective that specific treatment. So you see that medical nutritional therapy is very effective in decreasing that when compared with, for example, an ACE inhibitor, an antihypertensive, and a cholesterol drug. On the other hand, it also reduces costs, as you see, by decreasing the infection rates, decreasing the nosocomial infections, and decreasing the length of stay. I'm not going to go in detail, but you see that the nutritional care really decreases the healthcare costs, in addition to improving the clinical outcomes for our older adults. So how is the current situation? This is a figure from the Nutrition Day 2020 and 2023 Nutrition Day, international reference value. As you see, as an international value, less than 50% of the hospitalized patients are screened with a formal tool, so we are very behind our aims. And also, in only about 1/4 of the hospitals internationally, the nutritional status is being formally screened or monitored, I should say. And again, you see, in only about 1/3 of the patients, the energy requirements, protein requirements are determined, and malnutrition status is recorded in the patient record, despite our very well-known evidence behind this. So we can say that nutritional care is both a clinical and fiscal priority. adverse outcomes persist across care sections, from acute wards to rehabilitation, but also in community, being much more pronounced among community dwelling older adults. So we need urgent, coordinated and evidence-based strategies, and the prevention and treatment should extend beyond hospital walls. It should include community, hospital, and long-term care as well. So how can we do this? This is a table from the very recent publication from Alfonso Cruzientoft and Dorothy Volkert, our co-chair. And here you see in detail the strategies, the evidence-based intervention strategies and recommendations for prevention and management of malnutrition. So I'm going to try to talk about them in briefly. So in older adults, prevention of malnutrition is increasingly important because it develops more rapidly and it's more difficult to treat when compared to younger adults. So early and rapid intervention is key, and thereby we can address the nutritional problems. So all older adults should undergo routine screening at regular intervals, and this is regardless of their nutritional status. The frequency should, of course, change between the settings of the older adults, but all older adults should undergo routine screening at regular intervals. And as we said, it should be done with validated tools. And then if we find a risk, then it should be followed by assessment, individualized intervention, and monitoring and adjustment. So in this aspect, more collaboration with primary care healthcare professionals are needed. So among primary healthcare professionals, we should increase the awareness of malnutrition, particularly malnutrition related to aging and disease-related malnutrition. So we should enhance the nutritional skills of primary healthcare professionals. So we have now the Malnutrition Awareness Week, which we are now presenting some fruits of this week, and this is a campaign for increasing the awareness among the healthcare professionals, but also among many stakeholders. And now we are having the webinar on that. So also we have Nutrition Day, which is also brought by ESPEN, and it's important to stress about malnutrition. On the other hand, we should have interventions which should be individual, as we said. In the next lecture, we will have the strong evidence coming from the EFFORT trial, so I'm not going to go in detail. These interventions should be multimodal and multidisciplinary. What I mean, these nutritional interventions should include the protein and energy, fiber-rich food fortification, the supplementary snacks and finger foods, sometimes oral nutritional supplements, enteral and parenteral nutrition. Physical activity should be a core component of nutritional intervention, and some texture-modified fortified foods may be also very useful for dysphagia and chewing problems. Also, this should be multidisciplinary, so we should have the physician, nurse, dietitian, and when needed, physical therapist or occupational therapist. So this is a teamwork. So especially the availability and accessibility to dietitians in primary care setting will be very well. Another thing is to avoid dietary restrictions that may limit intake. So home-like pleasant eating environment, shared meal times, mealtime assistance, and energy-dense food may be very useful. And as we said, education is important. So nutritional education should be mandatory in all medical curriculum. So ESPEN has also a strategy for this, and ESPEN is ready for implementing medical nutrition curriculum within the medical faculties. And so ESPEN is here to help. Another thing is also education of informal caregivers. This can be also through social media, through news, through policy, and also older adults themselves should be educated in terms of nutrition, in terms of high prevalence of malnutrition and its devastating consequences. And the care should be integrated from acute to rehabilitation to community. There should be a continuous pathway, as we said, and the prevention should be across the lifespan. So in later life, as Jürgen said, the goal shifts from weight control to preserving muscle mass, bone integrity, and functional independence. So in community, in hospital, in rehabilitation, and for policy and administrative sectors, we have many things that we can do. So we know that most countries have some nutritional policies, but they lack funding. So this causes particularly harm for older adults. So the global strategies should include the reorienting food systems toward nutrient-dense foods, financing nutrition actions in healthcare budgets, training the clinicians, and integrating nutrition metrics into quality of life care. And we need help from journalists and media specialists. Journalists and media specialists can play a parallel role in communicating and leading the people to know that nutrition is not an optional lifestyle, not an advice, but it's a clinical determinant of recovery and independence. And as researchers, we should continue to build robust data to ensure these to policymakers and funders. So my last slides are my call to action. What we know up to now, malnutrition in older adults is common, related to adverse outcomes, costly, but curable in most settings. So prevention and management must be integrated across healthcare sectors. And screening, timely intervention, interdisciplinary collaboration, and sustained follow-up can really be useful in terms of clinical outcomes and also healthcare costs. So for clinicians, this means embedding nutrition assessment into every care plan. For policymakers, this means financing and enforcing nutrition standards. For journalists, it means shaping public perception of nutrition as essential therapy, not an optional life choice. And for researchers, we need strengthening the cross-sectoral evidence. So when health systems truly embrace the concept that nutrition is medicine, we will achieve not only longer life, but better aging for all older adults. I would like to thank you very much for your attention and will be happy to answer your questions.
Thank you, Gulistan. That was very informative. I think I will just go on to the next presentation, and then we'll answer the Q&As at the end, which we're keeping an eye on. So just keep them coming. We now have Philippe Schutz. He's an internist and an endocrinologist and a professor of medicine and endocrinology at the University of Basel in Switzerland. And he will talk to us about the EFFORT trial, which was already hinted by Gulistan. So please go ahead, Philippe. Thank you.
Yes, thank you very much. It's great to be here at the Malnutrition Awareness Week and speak about malnutrition, and also to share some of our experience we have with the EFFORT trial. So I think it's fair to say that in the last years, we really have made huge progress in the understanding of what is malnutrition. We have heard about it, how to diagnose it, but also how to treat it. And I think today the evidence has really risen, and we are at a much better point to say more comfortably how to treat malnutrition. And I think the overreaching goal today when we talk about malnutrition is really we trying to covering nutritional needs of our patients. And we know if we can succeed in doing this, we can improve patient outcomes. Of course, it is always important to understand that what are the nutritional needs is still a question that for different settings and different patient types, we still need to answer in more detail. But I think the basic concept to cover nutritional needs and also to have great algorithms how to go ahead with the screening, with the assessment, with nutritional goals, and then covering the needs, I think we have made huge progress. So here you see the current guidelines from ESPEN regarding polymorbid patients. And so a lot of these patients, of course, it's a big overlap between polymorbidity and also elderly geriatric patients. And I think today, when you also look at the evidence behind each of these single suggestions and recommendations has really increased. Because we have been doing a lot of trials, a lot of research, and I think the research has shown us where nutrition can have most effects and where also we may still need to do additional studies to understand how to best help our patients. And so I think one study that has been mentioned already, the EFFERT study, has been important to understand whether in a more general question, whether the effect of nutrition in a patient in the hospital at risk of nutrition, whether there is really a clinical measurable effect on hard endpoints such as mortality or also complication rates. And so the EFFERT study, and you see EFFERT stands for Effect of Early Nutritional Therapy on Frailty, Functional Outcomes, and Recovery of Malnourished Medical Inpatients. So this study has been funded by the Swiss National Science Foundation and has compared a nutritional strategy in hospitalized patients to a usual care group, which had the full access to food but did not have a nutritional strategy and no nutritional support in the hospital. So how was this strategy delivered to the patients? And I think the study had like 4 very specific goals in regards to treatment goals of patients. And you can see those 4 goals were, first of all, it was a caloric goal. So for each patient, we calculated how much calories should this patient receive. The second goal was the protein goal. And so here we used a high protein goal of about 1.2 to 1.5 gram proteins per kilogram body weight per day. The only exception was for patients with renal failure, for which we used a lower goal of 0.8 grams protein per kilograms per day. And then the third goal, which I think is also important in the inpatient setting, is use of micronutrients, because we knew a lot of these patients would come into the hospital, they would not have been eating for days, for weeks, and so they would have a depletion of their micronutrients and vitamin stores. And so all these patients also received micronutrients. And then we had some specific targets, such as for patients with renal failure or with chronic pancreatitis. So here it was very good also to have a nutritional team on board just to cover these special situations. And then for the study, it was important to have a clear nutritional protocol. So each patient systematically was screened upon admission. So we used the nutritional risk screening tool of 2002. And so the goal here was to understand within 24 hours whether a patient was at risk of malnutrition. The second goal was then definition of these individualized goals based on those 4 criteria. And then also we had an intervention goal with an escalation algorithm. And you can see we tried to be most physiological. So we started with oral nutrition, and this includes hospital food, of course. This includes snacks between meals, but it also includes ONS, oral nutritional supplements, as a very effective way to increase particularly protein needs of our patients. So if a patient did not reach these goals, or at least 75% of these goals within 5 days, then we had the possibility to further escalate to enteral or to parenteral nutrition. But in the end, we found that about 95% or 90 to 95% of patients, we were able to reach those goals just with the use of oral nutrition together with oral nutritional supplements. Now, what did the study show us? And I think when you look at these different outcomes, we first found that the risk of complications and also the risk of mortality significantly was lower in patients receiving nutritional care. But we not only looked at these hard outcomes, we also had several other factors which I think are important for our patients, including functionality. So we found that patients had better functionality after 30 days, and also the quality of life measurements we did found that patients reported better quality of life if they received nutritional care. Importantly, when we looked at side effects, then we found that the nutritional care did not have any meaningful side effects in our patients. And so, as we know from practice already, nutritional care is a very safe and very well-tolerated treatment for our patients. Now, those numbers are statistically significant, but it's also important to ask the question, well, is this clinically meaningful what we're doing? And so our main two outcomes were complications rate, which you see on the top, and mortality, which you see on the bottom. And I think the number you have to ask, if you want to know if an intervention is clinically meaningful, is the number needed to treat. So when you are in the hospital, how many patients do you need to screen and to treat to prevent one severe complication or to prevent one death? And you can see these numbers is somewhere between 25 and 40. I think this is a very low number, and it shows us that the work we're doing when we work with nutrition in our patients is a very, it's a very effective way to treat our patients. And you have seen just a slide before from my colleague. This is in the range of the top drugs we have. SGLT2, ACE inhibitors, or statins have about the same number needed to treat to prevent one death. So nutrition really is in the Champions League of these treatments. Now, we also did an analysis just looking at the elderly proportion, because the EFFERT trial was not a geriatric trial, but it was a medical inpatient trial. But a large proportion of our patients was also elderly. And so we also did a specific sub-analysis focusing on elderly patients. And so if you're interested in that, we also published these results. But basically, we found that elderly patients had most of the effects that we found in the study was really due to the geriatric elderly patient population. So the study was then published and had a very positive echo in the media, in the press, because it was the first study that actually proved, what Hippocrates has said many years ago, that nutrition is an important component to improve patients' health when you use it in your patient population. And while there is a lot of research out there for patients, I think EFFERT was important because the main endpoint was really a clinically meaningful end for mortality and severe complications. However, not all study questions are answered with this EFFERT study. And when we look a bit broader in the literature, we also find that there is a lot of trials going on, but not all of them report positive outcomes of nutrition. And I think this has also changed a bit the way we should use nutrition today. So when you look in the Lancet in the last 2 years, there were two very important studies. One is the so-called EFFERT protein study, and the other one is the PRECISE study. And both of these trials, they investigated whether a very high protein diet would be superior to a state-of-the-art protein diet in patients in a critical care setting. And so both of these trials found that more protein in very sick patients did not result in better clinical outcomes. And so I think this brings us to the nutrition paradox. So more does not necessarily mean better, but in some circumstances, actually more means less effect. And I think this is very important to remember when we treat the patients. We have to understand where are we in the treatment algorithm of the patients, what is the phase of treatment, and how much can actually the patient take in? Is he metabolically ready to be fed? And the reason why we should not overfeed our patients, particularly if they are very sick and if they're metabolically very stressed, there is two reasons. So the first reason, which has been found, is during a critical illness and when your patient is very stressed, there is important endogenous energy production. So your patient is producing energy, and so you only have to basically, with external nutrition, you just have to cover the gap between the endogenous energy production and the total energy requirement. If you try to cover all this gap, then you will give patients too much food, and this can hurt your patient. And why does it hurt your patient? And so here again, there are several hypotheses why too much food is not good for your patient in the critical phase of illness. And one of them is autophagy. And autophagy means cell detoxification. And particularly if your patient is very sick and you give too much food, then the cells of your patients are not able to actually use the proteins and the nutrition you give it to your cells. And then this can have negative effects on your patients. So it's very important to understand where are you in the treatment algorithm, where are you in the phase of illness, and what is kind of the amount of food for your patient to have optimal results. And so here you can see, for example, a treatment algorithm which is used in the critical care setting. And you can see, so this is from Arthur van Santen, which has published this nice review. And you can see most experts would recommend on the first day, maybe 25% only of calories, then increasing to 50% to 75%. And so have a stepwise increase in calories and in proteins. And also they talk about acute phase, post-acute phase, post-ICU phase, and then post-hospital discharge. And with each of these phases, you can increase then the amount of nutrients and the amount of proteins you can give to your patients. And I think this brings us to the point that we need to understand, well, where in the disease process is my patient? How can I understand whether I'm still in the acute phase or post-acute phase? And this brings us to the topic of individualized nutritional care. And I think this is really the future that we should have, an individualized approach and understand where is my patient and what is the optimal food and nutrient that I should use for my patients. And so here it will be interesting also to use biomarkers to understand how to treat my patients. So when I talk about biomarkers, well, what are biomarkers that we could think about for nutritional care? And of course, there is several biomarkers that are being discussed and being investigated in trials today. So there's some biomarkers related, for example, to inflammation, to metabolic stress, catabolism. Then there's other ones where you could maybe look at specific proteins in your patient. Then you have maybe your kidney function, which is important. You could have endocrine markers, but you could also have things like sarcopenia or hand grip strength reflecting the muscle of your patient. And I want to give you some example how these biomarkers could be used in a patient. So first, let's start to look at inflammation. So inflammation has been shown in the EFFERT trial to be the most important effect modifier for the effects of nutritional care. So basically, we found when you have patients that have very high inflammation, that their response to nutrition is not the same as patients with lower inflammation. And you see, we did a study where we looked at the C-reactive protein levels in all patients in the EFFERT study, because in all patients we had CRP measurements on admission. And so we stratified patients based on the CRP level. And so overall, we found this mortality benefit, as you can see here. In all patients, we found that intervention had this benefit in regard to mortality. And the same was true for patients with low inflammation or moderate inflammation. But interestingly, in the group of patients with high inflammation, so C-reactive protein higher than 100, we found that these two curves here, they flipped around. And so this was also in our statistical analysis, this was highly significant and showed that in the group of very high inflamed patients, nutrition did not have the same beneficial effect compared to the lower inflamed patient. So again, I think this gives us a signal that the higher the severity, the higher the inflammation, the more cautious we have to be with the use of nutrition, because those patients may not be metabolically ready for nutrition at this point. So another point which I think is now growing in interest and importance is muscle health. And of course, you all know muscle health can be measured with different tools. You can look at hand grip as a measure of the strength of a patient. I think this is very elegant because you can do it at the patient bed. You can also do it repeatedly and show the patient that they are actually increasing their muscle health over time if they are doing physiotherapy and if they are working with the nutritional team. So it gives direct feedback also to the patient. Another way to look at sarcopenia is also to look at the radiographs. And this is something also we did in our trial is we found that about half of all patients in the hospital within the last 1 or 2 months, they had a CT scan of their lungs or of their abdomen. And while we usually look at all the nice organs in the CT scans, we don't often look at what is important here in the back, which is the muscle. And so the muscle gives us a lot of information on the quality of the muscle, how much fat is in the muscle, what's the volume of the muscle. And also we found that this is prognostic for the treatment of our patients. And as you have heard before, I think this is also what is recommended for the future, that after screening of patients, we should also do a more profound diagnostic assessment. We should look at phenotypic criteria and etiological criteria. And here, reduced muscle mass, I think, is one of the important criteria also to stage malnutrition. And I'm sure it will also help us to better phenotype patients with malnutrition. And so I think this will be really important for personalized nutrition. So the better we can phenotype our patients and understand what is the true need of our patients, the better we will also be able to produce specific nutritional products and supplements and strategies to have best results for our patients. Now, and this is my last point, what I would like to share with you, what we also did based on all the data of the EFFORT study is to come up with an online tool which helps us to use all these formulas for the treatment of patients. And so if you're interested in this, it's a free of charge website. You can use this Clinical Nutrition Science. And you see on this website, you will have different calculation scores. And so the first one, the first score, and it follows basically the EFFORT algorithm, which starts with screening and definition of nutritional goals. And so the first one is just the screening tools. And then the second one is definition of individual goals. And so here you have different formulas you can use, which will tell you, it's pretty easy to put in the numbers here, and it would basically tell you what is the resting energy expenditure, what are the energy requirements, what are the protein requirements for your patients. And so I think it's a very easy tool to understand what is the best targets and nutritional goals for your patients. So I think in summary, nutritional care really has increased in the evidence about the effectiveness of nutritional care has really increased within the last years. And I also agree with the other speakers that today we really have to push for a proactive screening of patients using these validated screening tools, but also to then do an assessment using the GLIM criteria to really have a diagnosis of malnutrition. I think GLIM provides prognostic information and also helps us to select patients for treatment. And I think that in the future, the individualized nutrition will become more important. So for us, it will become more and more important to phenotype our patients to understand why is our patients becoming malnourished, what are the algorithms behind it, and then we can very specifically target those patients, I think, with these algorithms. And thereby we have a very effective mean to reducing mortality and morbidity in our patients. And that's the last word from me. And also I would be happy to answer any questions. Thank you very much.
Thank you very much for this excellent talk. We'll have time for a few questions. And I see that Marianne has answered a few of them on the chat, but there are still some open questions, and I'll just read some of them if that's okay, and then we can answer. And I apologize for butchering names. So Anastasia Lazaridi is asking, in cases of chronic kidney disease, nephropathy, and renal diseases that need protein intake and do have sarcopenia, would supplementation be enough for muscle strength? If someone would care to answer.
Could I take the question, having done some protein work? I think it's a big issue, sarcopenia in kidney failure and progressive kidney failure. But there has been some agreement on a cutoff of 30 milliliters per minute GFR. And above that, you should not restrict very much the protein intake. But below 30 milliliters, it's recommended to consider maximum of 0.6 to 0.8. I think that's a very fair recommendation to use this cutoff. And for older patients above 30 milliliters, there should be between 30 and 60, there should be yearly repetitious estimation of the GFR. And I think that's very reasonable. Otherwise, don't forget, combine always protein with training. And in this type resistance exercise, especially in patients on dialysis, etc., it's very important.
No, maybe I can also say a few sentences. ESPEN and European Renal Association published a paper, a consensus paper very recently. And in cases of advanced renal failure, the authors agreed that we should differentiate between the patients. Is it the chronic kidney disease is the main problem? So if it is the main problem, not the malnutrition and sarcopenia, then you can perhaps try to limit somewhat protein. But if it's the problem, an older adult, the main problem is being the older adult and malnutrition and sarcopenia, accompanied with a chronic kidney disease, then you should go on with high protein supplementation. And in any case, in any acute problem, someone shouldn't restrict protein, because we know that in catabolic stages we need more protein and more calorie. So that's important also, as you can say, in case of dialysis in renal replacement therapy.
Thank you. We have another question from Toma Asgarova, and asking if we could consider malnutrition not just as a nutritional problem. Wait, I was reading it and now it's out of my screen. Yes, if malnutrition not as a nutritional problem, but as a marker of biological aging and systemic frailty that should redefine how we approach geriatric care.
I don't agree. I have to pick this, sorry again. But malnutrition is not a marker of aging. This is a misunderstanding. There is a change of body composition that is coming with aging. This is very clear. But you may consider malnutrition to be a very important component of triggering frailty. I think that's very clear, but not necessarily related to aging per se. I think we cannot go there at this moment.
Thank you. Yes, I completely agree. I have a question from Elena Micheli, and asking if there are studies about the effects of fat against disease-related malnutrition and its complication. Then she said that proteins are important, but we should not forget that lungs and brain are fatty tissues and may help too with good recovering in older people. Would someone like to take this?
I do not fully understand the question, so that's why I'm not responding. I'm trying to find it in the chat, but...
Apologies. The question was basically if there are studies about the effect of fats against disease-related malnutrition and its complications. And I assume...
What I could answer to this is that next to protein, you also need to eat enough calories, because if you don't eat enough calories, then you will eat your muscle, if I could say so. So the provision of enough calories in the form of carbohydrates and fat is as important as an adequate provision of protein. And since fats are high in calories and in little volume, if a patient is severely malnourished, I do not hesitate to advise him to eat the more fat products.
Thank you. There's another big one here, and I'll just start with the first one. It comes from Agbogbo, and asking if in interventional studies, which variables are most sensitive for assessing the corrective effects of nutritional intervention.
Can you please repeat?
Yes. In an interventional study, which outcomes should be measured that are sensitive enough to measure a change if you're having intervention, if you have a nutritional intervention to correct, I guess this is for malnutrition specifically.
Yeah. But it's a pity that Philip has left, because, well, mortality is influenced by so many things that nutrition per se is not that much of influence on mortality. So the more important it is that he found results on mortality. But maybe you, Jürgen, or oh, there he is, Philip. Did you hear the question?
Sorry, I couldn't hear the question, the last one.
The question was which outcomes are sensitive to nutritional interventions, apart from mortality, that is influenced by many more factors.
Yeah, I think it's a good question. Of course, we have things like in the short term, we usually also look at weight and we look at muscle strength. You can look, which are surrogate outcomes then, and then in the end, you can also look at body composition, or then at your clinical frailty, and I think other clinical parameters. But in a single patients, I think we usually mix kind of. We measure the intake, we look at the weight, and this helps us just to see whether we are on track or not. And of course, in studies, you want to have some other outcomes also to measure.
Well, I would like only to add, it depends on your setting very much, and the trajectory you expect for functional decline or complication rate. So I think like Philip said, I think weight and intake check is very important, and probably body composition change. But if you go for clinical outcomes, it depends very much on your population and the speed of decline and the amount of deficit. And then you should adapt your outcomes. In the acute setting, I think complication rate in hospital patients could be also very interesting. Or Philip, would you agree?
Yes, absolutely. I think what we are really looking for, everyone, is a easy blood marker that could tell us whether the patient is well fed or not so well fed. And this is something we don't have actually. So nutrition is a bit more complicated. And I think it's more taking together really the different parts of the puzzle to make sure we are on track. And a lot of this is still, intake. And here maybe also we have some new IT tools where we can see that patient may, in some hospitals in Switzerland, for example, we have like a food scanner. You can see what goes to the patient and what comes out of the patient's room, how much did the patient eat. So I think there is also some other interesting ideas to kind of measure the adherence and the intake.
I was going to comment that measuring dietary intake is often not described in studies because it's so cumbersome and so difficult to do. So if we can make advances with new tools, as you said, scanning meals, etc., that would be great. But then if you scan a cup of coffee, you cannot see whether there's sugar in it or not. So we still have a way to go, but dietary intake is extremely important, and we hardly ever measure it correctly.
Yeah, Marian, I think the automatic way, AI-based, is a very feasible way to do it in institutions where we have a clear composition of the food components. But I think at home you're lost, like you said, because you cannot estimate the energy density, etc., if you don't know the product. So, but in institutions, I think I've seen the demonstration. It's a very promising approach, I guess.
There's a related question about diagnostic aspects regarding better integration of biomarkers. Philip, maybe you can go into detail a bit more about albumin, CRP albumin ratio, myokines, interleukin, and so on. Do you see a benefit of these biomarkers?
Yeah, thank you for the questions. So actually what we found is that the higher the severity of a patient, the higher the inflammation, the more severe a patient is ill, the less food you should actually give to these patients. And we found CRP seems to be a pretty good surrogate of the inflammation. We also looked at some other biomarkers for inflammation, IL-6, for example, or tumor necrosis factor alpha, and they all gave about the same information. Of course, you also, when you look at a patient and you have other medical information, you also get a sense whether, when he has very high fevers and so on, or if he's in ICU, you also get some of the information. So albumin, on the other hand, we found albumin not to be a very specific nutritional marker, because albumin is much influenced by the systemic inflammation system. And so typically for patients which are severely ill, they have low albumin levels due to the illness and not so much due to the nutritional part. So we also did look at pre-albumin. So pre-albumin has a much shorter half-life, and it seems to be a bit more related to nutrition. But as I said, today I don't see, kind of the perfect nutritional biomarker in the blood. And I think in the end, it's really a puzzle where you have to put together the different pieces and understand what's the disease, what's the age, what's the circumstances. And by doing this, then I think you can provide the best care. But this is something we will need to further advance in the future, also in regard to having a more systematic assessment and clear recommendations. Today, it's a lot of interesting research, a lot of interesting hypotheses, but I'm not sure if it's really ready for prime time in the hospital.
If I may add something, we should
Sure.
consider that aging per se is a resistance marker towards anabolic interventions. And we should not forget this. So it may be much easier to intervene with a nutritional therapy in younger individuals than in classical old individuals. So we really have to invest more to get an equivalent of change of nutritional status or body composition. So I think we haven't mentioned it, but there's something like anabolic resistance out there in parallel with aging. And aging markers, and this is something which we may be seeing soon, we will have biological aging markers based on a set of biomarkers. So I think this is something we can expect in the future to test the resistance to nutritional intervention in older populations.
Thank you. There's another question regarding micronutrients. Do you see specific micronutrients specifically important in older people in relation to malnutrition?
Well, it's known that vitamin D is often deficient. So I guess that's the number one. And you have to realize that if a woman eats less than 1,500 kilocalories and if a man eats less than 1,700 kilocalories, that it's likely that he will have one or more micronutrient deficiencies. The good thing is that we can supplement micronutrients pretty easily, while it's more difficult to supplement macronutrients. So apart from vitamin D, which should be supplemented to all older adults, I do not have specific recommendations, but perhaps Jürgen has some more.
No, I haven't.
Maybe we can also talk about calcium, because the calcium intake is generally very limited in mainly the older females, but also in older males. And maybe we can also talk about vitamin B12. It's very prevalent and it's important for cognition and for a variety of things. So we can also talk about vitamin B12.
Yeah, absolutely. But that's not a micronutrient. That's a vitamin, and like vitamin D. But of course, it's depending on the losses. So, of course, iron is a big thing in older population. You should not forget this. This is important also for heart failure. So I think iron is at the highest level of relevance. And sometimes if you do a lot of theoretic treatment, you should also check, of course, on potassium and magnesium. And of course, everything is true for vitamin B12 and vitamin D, of course.
But you have to realize that if you do serum determination of micronutrients, the body aims at a homeostasis. So it's very difficult to identify those who are at nutritional risk of vitamins and minerals. So therefore, a dietary intake is also very important, because the patient will only show a deficiency once it's way too late.
And one more addition, the use of proton pump inhibitors is very frequently used out of indication, and it decreases the absorption of iron and vitamin B12, also magnesium. So we should be careful about the right indication, and if there is an indication, then we should be actively looking for calcium, vitamin B12, and iron.
So,
yeah, of course, all micronutrients are as important as energy and protein. And yeah. There's a rather specific, maybe final question regarding Parkinson patients and protein and medication interaction. And specifically, Philipp Schützes asks what he thinks about food medication interactions and personalized approaches.
Yeah, so I think I'm another neurologist, but I think here the timing is very important. So, timing of food and medication, and I think you need to have a very strict diet then when you take your medication and when do you take your food. So in Parkinson's disease, because of the resorption, can be influenced by food intake. I think it needs a very strict plan here. But maybe there's someone more expert than me for this question, actually.
So maybe I may have some comment. As you said, Philip, the interval between the high protein meal and L-DOPA is important, because we know that the L-DOPA it intervenes with protein, and the high protein meal decreases absorption of L-DOPA, but it doesn't. The high protein doesn't cause progression of Parkinson's disease itself. So we should have enough interval. We should have the L-DOPA in empty stomach, and for maybe a half an hour or more, maybe an hour, the patient should not get the high protein meal. That's important, but the high protein meal doesn't cause progression of Parkinson's disease itself. It's just the absorption. On the other hand, Parkinson's patients are very prone for sarcopenia, for falls. So it's important for those patients to have enough protein, and also accompanied with physical training, the exercise.
Yeah, that's a good point, and also a comment in the Q&As, the importance of combining physical exercise and nutrition, especially in frail older people. And I completely agree that we should always look at both nutrition and physical activity. And I think that's a very good final remark from my side, at least. The time is over. Maybe Nuno, I would like finally to thank all the speakers for presenting, for great presentations, and also the audience for being there and for asking questions.
Yes, thank you to everyone. And just remind you that we'll have a joint webinar on the 11th of December, and more details will follow soon. Thank you, everyone.
Thank you. Have a nice afternoon. Bye-bye.
Nice afternoon. Bye.
Good afternoon.